In this segment, I'd like to discuss some very interesting in vivo data that looks at the efficacy in nimacimab and asks three important questions. And those are initially, what is the level of efficacy of nimacimab as it relates to some powerful incretin, notably tirzepatide? And we look at this with a suboptimal dose of tirzepatide as well as a more optimal dose of tirzepatide. And importantly, can we get a combination? This relates to the pillars, mechanistic pillars that we discussed previously, and this demonstrated some orthogonal mechanisms that we think would allow for a strong additive effect to occur when combining these two therapeutic approaches. So that's the first real question, looking at comparison and really the combination. The other question we wanted to ask related to a switch in the treatment. We look at this after 25 days, removing all treatment and asking the question, what is the durability of response without any drug present, and comparing the incretin to nimacimab? Relatedly, we also looked at the maintenance of incretin therapeutics at that same time point. So switching and removing the incretin therapeutic and swapping, if you will, for nimacimab, and looking at how weight loss is preserved over that time frame. This study used our human CB1 mouse model that we described previously. The mice were fattened with a high-fat diet, 60% fat, and the mice that were obese, generally 45 to 50 grams, were treated at what we call in phase A. So the phase A treatment included vehicle control, of course, and nimacimab at 240 mg per kg every 3 days. Now, this does seem like a high dose, and I would agree generally with this looking to be a high dose. What's important to understand, though, is when you look at the exposure, and that is an area under the curve analysis, what we find is that in mice, the antibody behaves very different than it does in human. In human, we know the half-life to be about 19 to 22 days. In mice, it clears very quickly. So we see the first half-life occurring in less than 24 hours, and the terminal half-life happening right around 3 days. And frankly, this behaves very differently, as I said, than the human setting. We think this may relate to the neonatal receptor and some other mechanisms, but ultimately, we have a half-life that's very short. And so when we think about the exposure, we're really matching that to what we believe the clinic over periods of active weight loss. And again, we can look at both the 75 mg per kg and the 240 mg per kg Q3D as being a very translatable dose. So just a quick aside and notation there on that. So the nimacimab group was compared to a tirzepatide group at 3 nanomoles per kg daily. That's a suboptimal dose, or a more optimal dose of tirzepatide at 10 nanomoles per kg daily. And finally, we had a combination. We wanted to ask that question, if we were to combine nimacimab with the suboptimal dose of tirzepatide, what type of efficacy will we see? And that would be the 3 nanomoles per kg daily with the 240 mg per kg Q3 days of nimacimab. So that first phase goes out to 25 days. And at that point, we switch over into phase B, and that is where we assess the rebound or maintenance with nimacimab. We'll get into that in just a bit as we move through the data set. So initially, we're looking at the curves, the weight curves, and we're looking at absolute weight on the left or vehicle-adjusted percent weight loss on the right. Both tell a very similar picture. And generally, you see that nimacimab is able to yield a notable weight loss. We see about a 21% vehicle-adjusted weight loss. We do see, interestingly, that the weight takes a bit to come off. There's a period where over the first few days where there's really no differentiation from the vehicle control, and then the weight starts coming off, and we see that eventually yield a nice curve. It's different than the incretins, which almost immediately at the first day, you can see some notable weight loss, and these eventually plateau and sort of reach an equilibrium weight loss that occurs right around 17 days on this study, and sort of maintain that weight out to 25 days. And so again, comparing the blue curve to the suboptimal dose of tirzepatide, you can see, in fact, that the suboptimal dose is able to engender more weight loss, and there seems to be a dose-dependent relationship with the more optimal 10 nanomolar high dose of tirzepatide, as one might expect. So we see this clear relationship from, again, about 21.5 to about 30% with the low dose tirzepatide, and ultimately the high dose yielding about 39% vehicle adjusted weight loss. Interestingly, when we look at the combination of the low dose of tirzepatide with nimacimab, we see some very nice additive effects. And ultimately, it goes beyond the high dose tirzepatide, yielding a 44% vehicle adjusted weight loss. And you can see that as well in the absolute weight graphs. This is very attractive from a translation point of view, a potential strategy to mitigate some of the AEs that are associated with this higher dose of the incretin, and you can still achieve that weight loss with a potential better AE profile. So this is exciting data and something that we think does have translational relevance. Now, what we did was we removed treatment of nimacimab actually on day 22, and we removed treatment of tirzepatide on day 24, so that on day 25, we're entering what we call the rebound or maintenance phase. And we know that based on the PK parameters I detailed earlier, we know that the drugs are mostly out of the mouse. So any potential residual PK effects are sort of blunted, and we're really looking at the potential for rebound. So just what happens when the drug is withdrawn. So not surprising, we see that tirzepatide is sort of a classic behavior. Here we're just looking at percent weight loss, moves quickly from its nadir, and at day 25, we're seeing this now climb up to the original 0%. This happens in less than a week, and eventually almost getting back up to the vehicle level of weight loss. So it's actually pretty similar to what the vehicle is by the end of that phase B, which is day 48. And this is in stark contrast to the nimacimab rebound, which is incredibly blunted. We are quite surprised and pleased to see, in fact, that nimacimab is able to remain very stable in terms of any rebound. We see this occurring all the way out. Remember, we pulled the drug at day 22, and all the way out to day 36, we have almost a very stable, almost no change at all. And there's a slight rebound that occurs as you get out to day 48. And just to put this in perspective, this duration rather is analogous to more than a year in a human. I mean, these are mice, and so as you know, days and weeks are elongated relative to a human, and so this is a pretty notable period to not have any meaningful rebound. Very pleased with that. This is data that's been reproduced, and we see this consistently occurring. The next question we wanted to address that's related but a bit different is the idea of switching the dosing now. So the same concept, again, the drug was stopped, nimacimab day 22, and the incretin on day 24. And then on day 25, we switch. So nimacimab is provided now instead of the tirzepatide. And we looked at this across a few different groups. So if we look at the low dose tirzepatide, and we can still see the rebound there for reference, you can see, in fact, that the addition of nimacimab in the salmon-colored graph provides a meaningful reduction in that rebound when nimacimab was applied as a maintenance therapeutic. So notable benefit in terms of its ability to limit the rebound. And you can see that clearly when comparing those two groups. We see similar level of maintenance occurring in the high dose tirzepatide. So with a high dose switching to nimacimab, we don't have the full rebound for that group, but you can see the maintenance coming out just below where the low dose tirzepatide landed. And ultimately, the same pattern occurs in the combination group. Here, it's interesting to note that there may be some changes in the metabolic milieu, such that the switch to nimacimab in the combination group seem to have a better effect in terms of blunting the potential rebound and providing maybe a better maintenance when coming off of the combination therapy. That's the purple group. So while there is a more narrow difference at the time of switching, you could see that difference between the purple and the red group are a bit more exaggerated at the end of the phase B timeframe. So this is quite interesting. we're investigating the potential mechanisms around that difference, how the phase A may set up a differentiated phase B as it relates to nimacimab maintenance. Now, the next slide, the next graphs that are, I think, very interesting relate to the specific fat mass. So we ran an echo MRI at different time points, and this helps us discriminate the body composition meaningfully. We're looking at the fat mass changes. We think this is a big driver based on our mechanistic details, the pillars that we discussed, and fat mass and lipid metabolism we think are related, along with energy expenditure details. And so interestingly, when we look at the composition, the weight of fat mass as we end that first period of efficacy, and the drug is getting withdrawal right at that intersection before phase B starts, we can see that the nimacimab is able to create a fairly stable, a slight reduction in the fat mass, and the incretins they do a really good job of driving those as well. And you can see that in the orange and red line, the combination, of course, driving the best. I mean, these are all really exceptional weight loss we're seeing. But interestingly, as we look to the end of phase B, so as you come off or switch, depending on the group of therapy, you can see some interesting behavior. So nimacimab in blue, you can see that fat mass has not gained appreciably. It's very stable. This is in contrast to the tirzepatide low group in orange, which has in fact put on regained a lot of fat mass in that rebound phase. And if we look at the other groups in terms of maintenance, that's the hashed orange line or the red and purple line, you can see again that there's a relative blunting of fat mass, but really contrasting by the stability of nimacimab, just highlighting the biology there that we think is very interesting. We're looking more into the mechanisms that are driving this very stable fat mass through treatment withdrawal. And if we look at the graph next to this, the fat regain, so this is simply looking at the change in fat mass relative to baseline and end of study, we can see again that stable lack of shift relative to the control mice with nimacimab in blue, whereas the tirzepatide group is increasing in fat mass. The fat mass is coming back when withdrawn. However, when we look at the tirzepatide that's in a maintenance phase with nimacimab, so phase A, tirzepatide, phase B, having the nimacimab maintenance, we can see again that fat mass staying off. So doing a really nice job of preventing some of that fat regain. And then, of course, we see the tirzepatide high also having fat regain, and the combination doing a much better job. So nimacimab alone, really nice preservation of fat mass, limiting the fat regain, and we see that when applied as a maintenance therapy, or even when applied as a combination. Lean mass tends to be very stable throughout all groups. There's some small movement, but by and large, this is really driven through fat mass changes. So that's the other side of the equation of the echo mRNA. The other key data that's part of the tirzepatide comparator study relates to food intake. And so one of the pieces that are frankly quite interesting is that nimacimab tends to have a relatively stable modulation of caloric intake. And you can see that on the left when looking at the daily food intake. And these are looking at sort of the total intake through time of nimacimab in blue, and both doses of tirzepatide low, again being in orange, and tirzepatide high in red, and then the combination in purple. And while you can see the sort of pattern that exists in the weight loss graphs, if you recall a few slides ago, you see a very similar pattern initially anyway with the food intake graphs, where the incretins have a sharp fall off and the nimacimab takes a little bit before it in fact starts to have some of that weight loss. We know mechanistically that the hormones that are modulating in the periphery are likely to be one of the drivers of curbing some of this caloric intake, and it might take a bit for those to get to their targets in the central compartment. Ultimately, though, we see that the calories tend to even out, and sort of you can see that overlay daily food intake as you move into day 17, ultimately into the end of that phase A portion at day 25. You can see that those are all very, very similar. Interestingly, on the right, though, when you look at the cumulative food intake, so go ahead and total those all up, you can see that, in fact, while there's certainly a reduction relative to the vehicle with nimacimab, the incretins are just providing a better level of reduction in caloric intake. This happens, in a dose-dependent fashion relatively with the 2 doses of tirzepatide, and we can see that the low dose is able to also have benefit in terms of the caloric intake when combined with nimacimab. So a pretty obvious pattern here. Ultimately, we think that the caloric intake is a key driver, but there's, I think, more to the story than just calories, and this becomes a bit more evident as we pivot into the phase B portion of the study, and then we again look at the daily food intake on the left to the cumulative food intake graph on the right. We can see this pattern even a bit more clearly in that the nimacimab group in blue is slightly elevated from the controlled DIO, but there's a significant difference between the nimacimab group that's in the rebound phase versus the incretin group that in orange that's in rebound. That's the direct comparator looking at just rebound caloric data. The tirzepatide group is eating significantly more than the nimacimab, even though neither of the therapeutics are on board at this point, speaking to a more stable caloric intake with nimacimab relative to tirzepatide. And this can be mitigated if we look at the maintenance group, and that is the group next to the orange. That's a orange border with the light blue shading, and that group has nimacimab as a maintenance in that phase B, and we can see that there is in fact a reduction in that food intake with that group. Same holds true to a lesser extent with the red group that's in that maintenance phase or the combo. The food intake is a key aspect that may help to explain some of the driver involved with the longer-term durability and as well as the maintenance phase. Collectively, this study highlighted a few key elements that we think are actually very important as we look to the clinical data. One, we know that nimacimab is able to combine well, likely through its orthogonal mechanisms with incretins, such as tirzepatide. It can transform a suboptimal dose of tirzepatide into something that has real efficacy, even beyond a high optimal dose of tirzepatide. And this might allow for a more safe approach to active weight loss. The second aspect of this study is highlighted that nimacimab is able to maintain its weight loss deep into a rebound state. This also has important translational relevance. And lastly, the study highlighted that nimacimab can be an effective maintenance therapy. This is evidenced through not only the weight loss curves, but we also see this in the reduction of caloric intake measured daily, or through the echo MRI data that showed fat mass preservation with minimal fat regain.